The 340B program should actually follow the patient. That's factually false. 340B is one of the resources that you use to serve your beneficiaries, the patients that walk into your doors, and to allow you to keep your doors open.
I don't think there's anyone in America that would say that the Medicaid systems are working the way they should right now.
It's 2026. We're in an election year. What do community health center advocates really need to know about how to be effective in today?
The amount of money going into Medicaid is shrinking. The people who need Medicaid are being shrunk. A significant portion are actually eligible for the Medicaid program.
Watching politics on television and getting angry, throwing a pillow at the TV because you don't like what's going on, that's not advocacy. Working towards permanency and moving to the other side of extenders is something all stakeholders should be working to. But the problem is we keep making it worse.
Welcome back to Community Health Centers Unfiltered, the podcast from Advocates for Community Health, where we go beyond the headlines to unpack the policies shaping the future of community health centers. I'm Amanda Pierce-Kelly, but for this episode, I wasn't able to be in the studio. I'm grateful that my colleague and trusted partner in this work, Margaret French, stepped in to co-host. Margaret is Senior Vice President at Venn Strategies and also serves as a Senior Advisor to Advocates for Community Health. She's worked closely with ACH for years, helping guide our federal advocacy strategy and navigating the complex policy landscape that community health centers operate in every day. Her deep experience on Capitol Hill and her long-standing relationships across the health policy community make her the perfect person to lead this discussion. In many ways, this episode is an insider conversation, a lobbyist-to-lobbyist look at how health policy actually moves in Washington. Margaret is joined by Debbie Curtis, partner at McDermott Plus, and Rodney Whitlock, Vice President at McDermott Plus. Both Debbie and Rodney spent years as senior staff on Capitol Hill, shaping major federal health policy, including Medicare, Medicaid, and the Affordable Care Act. Today, they advise healthcare stakeholders across the country on how policy gets made and how organizations can effectively engage in the process. Together, they pull back the curtain on how power really moves in Washington. Because for community health centers, understanding federal policy isn't just about reading the final legislation. It's about understanding the negotiations, the trade-offs, and the relationships that shape the outcomes. This conversation offers a rare behind-the-scenes look at how policy becomes reality and why community health centers need to be a part of that conversation every step of the way. And with that, I'll turn it over to Margaret French, who's in the studio with Debbie Curtis and Rodney Whitlock. Enjoy the conversation.
Thanks, Amanda. Welcome back, everyone, to Community Health Centers Unfiltered with two incredible guests today, Rodney Whitlock and Debbie Curtis. They are no strangers to DC and actually no strangers to the podcast scene. Rodney and Debbie have a weekly podcast, the Healthcare Preview, that comes out on Mondays. So want to encourage all of our listeners who are interested in health politics and policy to tune in. Healthcare Preview on Mondays. But before we get into the questions, can you tell our listeners a little bit about who you are and why they should care about what you have to say? Rodney, you want to go first?
That was a high bar. Why do they care? Okay. I'm Rodney Whitlock. I am a principal at McDermott Plus. I spent 21 years on the Hill, 10 years in the House, 11 years in the Senate, working a lot of Medicaid safety net issues while I was there. Got to a point where the retirement thing was offered to me and I took it because it would have been rude of me not to. And so I've been on the outside now for 10 years doing the consulting thing where we help people understand the Hill, how it works, and how to accomplish things there. And the cool part about my job is I get to work with Debbie.
Oh, that is very, very nice. Cool part of my job is definitely working with Rodney. And we like to say, that I'm the D to his R, he's the R to my D. So I likewise spent 20 plus years on the Hill. I stayed on the House side. I never grew up like Rodney and went to the Senate side. But I worked mostly with the Ways and Means Committee, was on staff there and was also chief of staff to the Health Subcommittee chair in a dual role there, and helped to pass the Affordable Care Act. Once we got the Affordable Care Act done, I crazily decided to go help implement it in the District of Columbia because I thought if you're going to make a law, you ought to help make it work. And why not help make it work in my community? So anyone thinking of doing that, give me a call. If you decide to help pass a law and then make it work, it's harder than they tell you. But I am really thrilled that I did that. And I have now been with Rodney at McDermott Plus for almost 5 years. And what I would say is what is really gratifying in the work that we do and in having left the Hill for a while and come back to work with the Hill is that we are able to work with groups like you all to help navigate the Hill and to help create strong policymaking at a time when that is not necessarily at the front of the list of things that are on the mind of Congress.
So you rattled off a pretty impressive resume, both of you. Working for that long on Capitol Hill and then taking some time away, Debbie, and then coming back. Can you just reflect a little bit about how the Hill is different from when you were a staffer?
Okay, first, I'll say the positives first. You get paid better now on Capitol Hill. My first job on the Hill was $12,000 a year. Okay, think about that. Wow. I had student loans. I had rent. It was a very scary time.
It was in the era of typewriters, all right? So, let's be frank.
It was still impossible to live on $12,000 a year. It was impossible. So the pay is definitely better. I think other changes, maybe not as positive. And actually some are. The thing about the Hill is it is a lot like a college campus. And you get to be friends with people you work near, that you live in the hallway next to. And when I say live, when you work on Capitol Hill, sometimes you almost are living there. You pull all-nighters. You're there until 4 a.m. I used to get walked home during the ACA by a local gentleman in my neighborhood on the Hill who was homeless, but he knew I would come home late and he would get me so that I wasn't walking home alone. That is kind of the community that is the Hill and the broader Capitol Hill area. But, what has changed is just the divisiveness that's up there. And I don't say that to mean that it used to be everybody got along. That's ridiculous. There have been partisan differences forever. But when I worked for Pete Stark, one of the things he used to say, and he was a congressman from the San Francisco Bay Area, and what he used to say is when he first came to Congress, the fights about health policy were not on partisan lines. They were about whether you lined up with the doctors or you lined up with the hospitals or you lined up with the community health centers per se. But it wasn't partisan. And that really all started to change in the 90s. And that progression has just continued. So the divisiveness, I think, is significant. And I also think members of Congress do not get to spend as much time thinking policy as they did in our day when we were up there. The pressures on them on fundraising and just constantly fighting to keep their job, keep them unfocused on that. And the emphasis is to be at home in their districts as opposed to in Washington. And I really feel like the work of in Washington is as important as the work at home. And so that's a little hard thing for me to watch, I think.
Rodney, what about you? You sort of went right from your, 20 plus years on the Hill to downtown. So in a way, you never really left. Can you reflect a little bit about some of the changes that maybe Debbie didn't touch on that you've seen?
Well, I agree with certainly most everything she said, that we have the partisanship. The kids there now who are doing the jobs, they don't know what it's like to get in rooms and try to work together. And Debbie and I certainly did that when we were there, because it's what you did. You worked together. We always had bills to work on, and you tried to get across the finish line with legislation, and you find compromise. Boy, they don't do that as much now, and that's really challenging. That the younger staffers have never really learned that process of how do you make legislation? How do you work out compromises? How do you get things through the process? And so that's certainly been part of the change. And for us and what we do in that transition, it makes it that much harder, and you have to reset your expectations accordingly as to what you think can be accomplished. What is the realm of possible? Very different than our area.
And so now it's 2026. We're in an election year. What do community health center advocates, our listeners to this podcast, really need to know about how to be effective in today? How to be effective when we have, a limited economic situation, distractions abroad, and, the November midterms really looming large above all the political and policy decisions being made right now?
I'll start. Do your job. Do your job. What's your job? Advocacy, right? Because listen, we're living at a time where there are a lot of things going on, and healthcare may not be front burner. Heck, it may not be on the stove at this point, given everything else going on in our world. But you know what? The people who do the jobs, the people who work for the committees, the people who who are implementing legislation, you know what? They come to work and they still do their job, which means we need to show up and do our job, which is advocating on behalf of the communities we represent, the providers we represent, stakeholders we represent, because we're not stopping just because there are other things going on in the world. And so I think that's really important to understand as a baseline. You got to go back to doing your job no matter what's going on.
Yeah, and I'm just going to say what Rodney said a little different way, which is just because we're not the front page doesn't mean we're not in the paper. And boy, that just made me sound old. Because who has a paper anymore? But, the point being, exactly as Rodney says, the focus may be international right now for very, very good reason. But there's still health work to be done. The Ways and Means Committee has a health subcommittee. The Energy and Commerce Committee has a health subcommittee. We've heard Education in the Workforce is getting ready to have a big hearing on healthcare sometime in the near future. This work continues, and you need to be up there and influencing that work with your priorities. And I think, the good news for someone like the community health centers is you're all over America. You're in people's communities. You are known to the members of Congress, and making that tie from the role that you play at home and the needs that you have from Washington is so important. And one of the things that I just always say to people is coming to Washington and trying to influence policy is so important. But if you don't follow up with it at home and you're not seen at things where that member of Congress is going to connect, oh yeah, community health centers are watching me, or whoever you are, you're not going to be as effective as you otherwise could be.
Watching politics on television and getting angry and, throwing a pillow at the TV because you don't like what's going on, that's not advocacy. It's not. You got to get off the sofa and do the nuts and bolts of helping members of Congress understand. If you think the pillow is making a difference, you might need help.
Though, if it helps you to throw the pillow, you can do both.
Okay, don't break anything. Don't break anything.
We're going to get into some kind of how they do that tactical questions in a bit. But I want to switch topics now to really the lifeblood of community health centers, which is the Medicaid program. We saw through HR 1 some significant changes pass through Congress and be signed into law by President Trump. And right now, CMS is working to put out rules to implement a lot of those changes, which we're expecting to see this summer. Can you talk about how the Medicaid program is viewed right now amongst Republicans and Democrats, and what advocacy points in the Medicaid space really resonate with members of Congress? So how the program is viewed overall and how we can help shape it.
So I think if you look at the One Big Beautiful Bill Act, or OB3, depending upon which direction you want to go, the fundamentals of what they did in that bill from the Republican perspective, since it was solely a reconciliation bill and solely a Republican effort, they took on effectively eligibility and really wanted to focus on making sure that people who are eligible for benefits are getting the benefits, and people who are not eligible for benefits are not getting benefits. Basically making sure that you have a fundamental level of people being eligible, getting the program, and nobody else. And that's, I think, important from the Republican perspective. Fraud, waste, abuse now coming into focus behind that. I think the second area is the concept of work requirements. And Republicans have believed for generations that the population that was called the expansion population under the Affordable Care Act, those that were outside of women and children and disabled and aged, that those were the folks that should otherwise be in the workforce. And Republicans, their perspective was, and had been for a very long time, States doing things to help those individuals actually move into the workforce is a good thing. And that was their perspective on that.
Right.
And lastly, state funding mechanisms. We've all been around here for a while. We know state funding mechanisms that allow states to bring down federal dollars. The state's incentive structure has always been maximize, without question. That's how much how much federal money can we get to, as much as possible, supplant state dollars. Let's be frank. Doing differently is called malpractice. That's your role as a state to do so. And Republicans took steps to curtail those practices. And so from a Republican perspective, nothing radical there. Democrats might not see it that way.
Democrats definitely don't see it that way, but that was a really good explanation of what they did through the lens of why they did it. And I think if you were to say to almost any Democrat on the Hill, what words would they use to describe Medicaid right now? They would say at risk. And I think that is you can full stop right there. I mean, I think they are very concerned that these policies put forth are actually intended to, well, they're not intended. I will say it this way. While they may be intended because work is a good thing and people should be working and, we should monitor exactly how funds are spent, that the effect of the policies that they've put into place is that the amount of money going into Medicaid is shrinking. The people who need Medicaid are being shrunk. And some portion of those people, potentially a significant portion, are actually eligible for the Medicaid program. What these work requirements will actually do through the mechanisms in order to prove that you're working, end up having people lose Medicaid eligibility who absolutely are eligible and actively working. And that those administrative burdens that are being put on Medicaid enrollees are going to result in loss of coverage. And that's going to mean more uncovered people. It's going to mean uncovered children. It's going to mean growth in uncompensated care. It's going to mean people aren't getting the upfront health care they need. And in fact, while it's designed to save money, the effect may be actually to cost money and certainly to cause real quality of care problems for significant portions of our population. And so I think for Democrats, the at-risk component is really number one.
I think the Republican perspective in response to that is effectively, okay, if I can pull out my phone right now and I can tell you how many stops a package has to get to my house, okay, states can find a way to be a little bit more creative in terms of their use of information technology to be able to keep up with their beneficiaries, find them, ensure that they're eligible, to help folks into the workplace. Not going to argue with you that the money's going to be tighter with the restrictions on state funding arrangements, but less so on those two.
So, but here's just, look, I don't disagree. Could more be done on the technology front to be more aware of, what's happening in the Medicaid program? Yes. I don't think there's anyone in America that would say that the Medicaid systems are working the way they should right now. But the timelines that are put in place for this, the pressures on states, remember, states are funding a significant portion of Medicaid. Unlike the federal government, they have to actually balance their budget every year. They have real constraints on how they can spend money. And, all of this happening all at the same time with a whole lot of changes, with absolutely, we can just say it, decrepit IT systems. We can criticize why they're decrepit. Those were choices states have made not to do some of the things that should have been done. But the impact of all of this all at once is people losing access to needed services. And so the timeline, and can you stretch this out? Could you do this over a longer period of time so that people weren't the losers in this scenario? I think that's a lot of focus that you'll see from Democrats.
Yeah, and the joke I've made, and you've heard me make it, which is at some point in time, Medicaid cannot continue to use the excuse we use wangs and punch cards to be able to operate our IT systems is an acceptable excuse.
But if they are still using them, it is an acceptable excuse. And I agree, we need to do something to fix it. But boy, we've got problems on that front. I mean, look, that's no different than the infrastructure in America as we drive over certain bridges in the DC area, right?
No question.
I mean, we do not like to invest in infrastructure and maintain things because that's not the fun spending.
Yes. And kids, if you need to understand what a punch card is, go ask your grandparents.
Well, you know, it's interesting to hear the motivations, but the reality is the law is passed and they're moving forward with implementation. So what would be your advice to health centers specifically as they are navigating the proposed rule and finalization of the rules from CMS, and as they are continuing to engage with their congressional offices on impact and pain points?
If you have areas where you know you're concerned, you can do some plowing of the fields right now with your members of Congress. You can let them know, hey, if CMS does something like this, it will be a problem. And we're going to have a hard time with that. So that way, when CMS does it, you get to come behind and say, okay, they've done it now. It's a problem. Can you help us out? I think that's the type of work you need to be doing right now based on your perception of what could be coming and why.
And I think you need to not be only doing it with Congress, you need to be doing it with your states, because again, Medicaid is a shared federal state program. The law as written does permit some flexibility for states who are having a hard time meeting all of the terms of the law. If you know your state is in that situation, your state knows it's in that situation, and you can help make that case to Congress that flexibility needs to be given, you want to be doing that. And then Congress can encourage the administration to do that. There's going to need to be a lot of close monitoring of how implementation is proceeding and ability to speak out quickly after that. I think also, just raising it back up, Margaret mentioned we're waiting for regulations. They're supposed to come out in June on the work requirements. If they don't come out in June, if they get caught up, which sometimes in Washington, things get delayed. It does sometimes happen.
No.
If that happens, that's going to have a real impact on states' ability to implement what they're being told to implement. And so monitoring this very closely and keeping that active conversation so that if we need to hit the pause button for certain things, hopefully this can be achieved, because it's not saying don't implement this. It's saying, this came out really late. We want to be successful. Hopefully we agree we don't want to unintentionally kick eligible people off the program. Maybe we can work together here.
I couldn't agree more, Debbie, with what you said on the triangulation between, your federal representation in Congress, your state and local folks, and, your advocacy, and getting those groups to sort of speak to each other and speak to CMS on your behalf. And that echo chamber has been among the most effective techniques that we've used at ACH to really break through the noise. Switching topics, it's everyone's favorite topic, 340B. There has been a lot of developments this year, and I would lump 2025 into this year because it's this Congress on the 340B front, both in the courts, at HRSA. We've seen manufacturers take a number of different actions unilaterally. Can you talk really briefly about the status of the 340B program and what ought health centers be doing to underscore the importance of that revenue stream for the populations they serve and for keeping their doors open, frankly?
Spreading scarce federal resources. Those are the lines that were written into the report language when 340B was created. Repeating that over and over again, because there are folks out there whose job it is to convince members of Congress that, in fact, that's not what the 340B program is for.
Right.
That people are doing our jobs well paid to go out and convince members of Congress and their staff that the 340B program should actually follow the patient. That's factually false. Your job is to get out there and help folks understand 340B is one of the resources that you use to serve your beneficiaries, the patients that walk into your doors, and to allow you to keep your doors open. And you use it because that's what it's for. And anything that threatens that makes it harder for you to do your job.
100%. And I also think an important component here is that right now, as community health centers, hospitals, most any any of the covered entities are facing significant uncertainty with the passage of the One Big Beautiful Bill Act and the changes that are coming in Medicaid. And that now is not the time to be pulling yet another lever that endangers funds that are coming in that make you able to be a safety net provider. I mean, you are getting this funding through 340B because we all know, and frankly, Congress recognized that payments from Medicaid and uncompensated care and Medicare, if that's who you're treating, you need someplace else to pull some funds from to be sustainable. That's what 340B is. If they pull that line at the same time that they're pulling the Medicaid line, disaster could ensue. And I think it never hurts when you're doing advocacy on the Hill. 340B is a program, it's a program you depend on. But on Capitol Hill, and I say this as someone who worked at the Ways and Means Committee, which did not have jurisdiction over 340B. So I loved when I worked there saying, hey, we're with Henry Waxman on 340B. But I didn't have to. And frankly, because it's a complicated program, I didn't really want to have to go beneath that. So for a lot of members of Congress, because they've only heard from pharma the loudest about what the program's supposed to be, they don't know. And so you reminding them that this is one of the very few programs where the dollars are actually coming from the pharmaceutical sector into safety net providers. And that if they change that, are there new federal dollars to follow? I don't think so in this day and age. And so I think that education, don't ever presume people get it. Spend the time talking about that.
I want to move on to the Community Health Center Fund. So in February, we had, frankly, the biggest win we've seen in years. We had a not CR authorization of the Community Health Center Fund, and it was actually at a modest increase. We just talked about the tough economic times and the tight federal dollars. So given that circumstances, can you talk about what a win this was for the health extenders and maybe talk about some things that we should do to ensure that the next cliff we're facing, which is at the end of this year, is handled?
And which is the end of this year, which is not that far away.
No.
I mean, that's what's scary is you have a victory like that. And that was such a victory. I mean, like, I can't tell you how excited I would be to tell someone. I get excited that we extended something, and it has an increase in 2026. Yeah. Good gracious. That is a huge victory. Now I will say, huge victory, very, very important. Bummer, it's only 1 year.
I know.
Like what you really want to do is try to get these things for several years, because then Congress goes away and thinks about other things before they come back to panic about you again. But that's not the situation we're in. And so what you all need to do this year is show how that money was used. You need to show how important that funding was and what it enabled you to do more so than you could before, and why sustaining that, because the difficulties for community health centers are only growing as implementation of OBBBA continues. And so that's the case that you make. And we don't know the scenario we're going to be in. Look, it's an election year, which means any tough decisions Congress is going to make are going to happen after the election. They're going to come back for what we call a lame duck session. We know that there are expiring provisions in healthcare, with the Community Health Center Fund being one of them. So we know that's going to necessitate legislating. It can be a kick the can, or it can be doing something better, doing something different, doing something more. And so that's what we're using the rest of this year to push for.
You and I might not be in complete agreement on this, and that's okay. I think that working towards permanency and moving to the other side of extenders is something all stakeholders should be working to. But problem is, we keep making it worse. Right? We had the physician payment fix, the so-called docs fix, for a generation that we had to deal with year in, year out. And when we thought we fixed it, you know what? We need to address it again. We've got disproportionate share, dish hospital payments. That's now an extender, and it's going to keep going. We now have, telehealth as an extender that we're always going to have to be addressing. That because that genie is out of the box, Pandora out of the bottle, whatever metaphor I just muffed. That's not going anywhere. Healthcare stakeholders, I mean, the incentive is we'll take 2 years and live to fight another day. Okay, and Debbie and I will have retired watching that occur forever and ever, and the next generation will come along. And as much as you can to try to fight anybody who wants to say, well, we're just going to do this for a year and see what happens and come back on any policy level. Starting there might be a good place to start, which is say, okay, no, don't do that. We need to finally settle on some of our extenders, clear the decks so that we can move forward.
That would be great policymaking. But I think it's also important to remember, and for, even if that happens, just because Congress says something is permanent, nothing is permanent. So it can still be changed, but it takes you out of the cycle. And to me, just reminding Congress, you do this permanently. Yes, you have to make a financial investment up front. That's what stops all of this. It's money, and being able to make that commitment of funds. But if they do that, that frees them up from having must-pass legislation that ends up having them having to scramble for money and spend money. And if a program they decide shouldn't continue the way it is, that's what Congress's job is, to change it. So permanent is not, it gets us out of this ridiculous situation that we've been in for so long, but still opportunity for change.
So speaking of money, I'm hearing Medicaid changes and disruption. I'm hearing 340B erosion. I'm hearing CHCF still needs to be reauthorized along with a bunch of other stuff. How can health centers advocate to their federal officials without just seeming like our hands are always up and we're always asking for more? How can we communicate that need without, coming off a certain type of way?
I mean, in certain respects, you got to get over it because you don't have an option.
Right.
But you do always start with your fundamentals. And those are the beneficiaries, the constituents that you serve. And that, every meeting should start with your story of who you are and what you do and why you're important. That then at least makes the case as to why the money matters. Skipping that step, now that is unseemly when you come in just asking for money. Never forget to lay out the case as to why you're so important. And
that is perfectly said. But to go along with that, you don't only do that when you come to Washington. Whenever something positive is happening at your community health center, you are sending that information to your members of Congress, to the delegation, to the staff that you have relationships with. When you have opportunities to invite them to partake in announcements that are positive, that brings them in as partners for you. And I think over my time in Congress, I think community health centers are among the most effective at being able to do that. There is an ownership. You're in my community. You're taking care of my people. We're going to work on this together. And you just need to constantly work on making sure that this is a relationship and a partnership, not just an ask.
Well stated.
So I want to close out this episode with a little bit of a crystal ball.
Oh,
what's ahead? We've been dancing around Medicaid regulations, elections, other activity. For the health policy folks that are listening, what do they need to be concerned about in the near term, maybe the next few months, and then for the rest of the year?
I'll do the near term.
Okay.
Oversight. That we have seen an increased focus on oversight. And that means both at the CMS level and at the congressional level, going out and chasing certain things to try to see, hey, is there fraud and abuse here? In politics, there's a saying, if you're explaining, you're losing. Not in this case. In this case, if there are accusations out there about how much someone is being paid and how much it is versus others, and is it too much, or is the growth too, whatever, what's the explanation? And if that explanation is a good one, we move on. If it's not a good one, we have problems. And so I think that's going to be a dominant theme in healthcare in the months to come.
It is the dominant theme, and it's the theme in the administration, and I would put it way higher than just CMS, because the president in the State of the Union put J.D. Vance, the vice president, in charge of this, and he's going to want to show results, and that means there's pressure at the CMS level for them to produce things. And we just saw yesterday a letter go to New York with 50 questions to New York. New York has a huge Medicaid program. We all know this. We all know the New York Medicaid program is pretty unique, and boy, are they asking a lot of questions to have that explained. And Rodney's right. If they explain it well, that can go away. But these opportunities to ask questions, we have hearings going on right now on the Hill on what's happening in Minnesota and home and community-based services. So that focus is not going to stop. And that has the real ability to impact policymaking if it goes forth unanswered and they spotlight things that they decide they want to legislate on. Even if those things may not be the real truth of what's happening in that sector, it can be too late to recover from that if that impression is out there. So that's huge. That is the rest of this year. Now, when we get through the election, that's the lame duck session, and that's where we know we have expiring provisions that need to get done. And the community health center funding falls right there. There is every reason to believe that Congress will legislate a healthcare package during the lame duck session.
Right.
The question mark is, will it be a big one or will it be the bare bones package? And that's the work to try to make it be more rather than less. And let's also remind ourselves, this is less an issue for you all because it's hard to take money out of you. But you would
think, Debbie, but they
find ways. People always find a way. But it is also true that with opportunity come risks, and a package that gets done has to be paid for. So you have to always watch from that side as well.
Yeah. Just real quick, I think and looking ahead, listen, it's going to be hard. The folks up there are not playing well together.
No.
And so, it's an uphill climb. But choosing not to try guarantees an outcome.
100%.
All right, let me ask you this. If it's a bigger package, if the stars align and, lawmakers are feeling extra generous, what type of things beyond the bare bones are even a possibility? We've seen them do some work on physician pay. Is that a possibility? We've seen them, do some work on the workforce front, to your point earlier, Debbie. Could some of those provisions be in there? Or do you really think this is going to be a skeletal sort of extenders only package?
I think it's too soon to tell right now.
Yeah.
And I think, frankly,
Fair
a
enough.
lot of that is dependent upon what people do in the advocacy realm in order to make the case that something needs to change. The other thing I want to put on the table is if Congress decides they want to do something that is a saver, that saves money, and I'm going to pick something, and no one call and yell, I can't believe you're picking on that. But if they decide to do something more on upcoding in Medicare Advantage plans, just because that's something that's been talked about a lot.
Sure.
If they were to do something there's savings attached to that. And then they're going to want to spend those savings. And so that opens the door for the more getting done in that package. I mean, the limiter here often is, can they come up with the money in ways that they can agree on? And, agree on is really the number one limiter of all of this stuff these days.
Yeah.
Exactly what you said.
All right. Final question. You didn't think I was going to let you off the hook without a little bit of a 2027 predictor, right? It's an election year. I know it's March, but Debbie, right now, House, Democrat, Republican, what say you?
Democrat.
Rodney.
Oh, it flips. I mean, we've had 13 elections this cycle. We've had 11 flips.
We've got 2 flips here. All right. Senate, a little bit harder of a case for Democrats there, but can they get the job done? Debbie.
That's a very hard case. I'm going to give the answer that it's not impossible, but boy, it's hard.
Coin flip based on the outstanding primaries. Certainly, Texas last night went the way that I think Democrats felt like that it needed to go for them to have a shot at Texas.
Yeah.
Maine, Michigan, got to see who the candidates ultimately are.
I agree, but I'm just going to say as a Democrat that when you're putting your heart on Texas, it makes you nervous.
Well, on that note, Rodney Whitlock, Debbie Curtis, McDermott Plus, thank you so much for coming on the podcast, Community Health Centers Unfiltered.
Before we wrap up, I want to thank Margaret French for stepping in to co-host this conversation and for the leadership she brings to ACH's advocacy work every day. And of course, thank you to Debbie Curtis and Rodney Whitlock for sharing their insights and giving us a behind-the-scenes look at how health policy really moves in Washington. For community health centers, understanding the policy landscape isn't just about following the headlines. It's about understanding the process, the relationships, and the strategy behind the decisions that ultimately shape access to care for millions of patients. Thanks for listening to Community Health Centers Unfiltered. If you enjoyed this episode, be sure to subscribe and share it with colleagues who care about the future of community health centers. Until next time, thanks for joining us. Thanks for everything you do at the health center.